name is Dr. Mari Mitrani. My name is Maria Ines Mitrani, but it's a little complicated. So I've always go for Mari because I know that everybody can pronounce and say my name as Mari, and they don't chop it up in different ways. So I am the Chief Science Officer of Organicell and the co-founder of this company. So a lot that I'm going to talk about is about our journey or my journey into where I am right now as the Chief Science Officer. I started just like one of you with the interest of pursuing medicine as a career. And never in my wildest dream would I thought that I would ended up being a physician scientist. I always thought that I was going to be in the clinical setting, seeing patients in, just the desk and receiving the patients, analyzing their data, and then trying to offer some solutions. I am, let me go ahead and hit next. I got my medical doctor degree in Ecuador. I am from Quito, Ecuador, South America. So I went to med school there at Universidad San Francisco, a really amazing school. Our setting in Ecuador is totally different than the States. So, but nevertheless, still same 8 years to complete that. And recently, I got last year my certification on plant-based nutrition from Cornell University, understanding that nutrition is one of the biggest components if you are trying to gear into health. And if you are planning on being physicians, please make sure you include some kind of nutrition certification because unfortunately, none of the universities no med schools will train us on nutrition, and that is the base for health. So that's a little 2 cents for me. I got my PhD on neural therapy. We worked on the sympathetic and parasympathetic nervous system, and my doctor of acupuncture as well. I've always been geared on regenerative medicine because my father is a physician. My mom always worked with him. She specialized more in nutrition and diagnostic techniques. So I was born and raised in a house where we were at the clinic all day long. I never thought I wanted to become a doctor until I was in my last years of high school when I was starting to study anatomy, biology, and I was so fascinated at everything. And it just now clicked in the fact that I was extremely fascinated on the cells and the cell division and every aspect of that. And never did I think that I was going to be specializing after almost 2 decades on just that. So I also have a missionary medical doctor degree from the Suburban Medical Order of the Knights Hospitallers. I love to do as much as I can for our communities. I come from a third world country, so you can imagine how much medical need there is. So that is one thing that I have learned from a bit of the beginning of my med school years. I was able to volunteer with these doctors abroad that go and perform surgery and other kind of medical things in a third world country, and was fortunate because I am trilingual to translate from these physicians from the US and Canada to be able to care for patients in need. Under some of the certifications that I do have the certifications in human subject research and GCP for the clinical trials and investigational drugs for the US FDA. So to tell you a little bit about my story, I graduated as an MD, I got my PhD, I got my doctorate in acupuncturist, and I was more into anti-aging. I was managing my parents' clinic in the med spa side, and really liked that aspect of anti-aging, trying to approach anti-aging without being invasive and trying to bring the body into the best aspect without any addition of chemicals, right? So there was a number of devices and things that we discovered. But we're presented, me and my husband, with the opportunity on opening a stem cell, autologous stem cell clinic. And we didn't know anything about it, but trusted the masterminds behind it, hematologists that were working for 25 years with autologous stem cells. So that long story, I'm going to make it a little short. We were able to open this treating facility, research and treating facility in Quito, Ecuador. And we went from a really small office to almost like a small hospital. It became a big clinic where we were able to see patients from everywhere in the world, from every condition that we were able to treat, and just learning and exploring and understanding the ability of the patient's own stem cells being collected, separated, and then injected back into the patients was unbelievable. I took a little clip from one of the testimonials that one of our patients left, happened to be the actor Danny Glover. But from like Danny Glover, many others passed through our clinic. And for us, we started to see miracles happen. And all of a sudden, those miracles were repeated over and over and over, understanding that all of a sudden, those were not miracles. They were actual results that can be done with a specific technique. So what brings me now to be the chief science officer of a public company that is focusing on a product that does not contain stem cells. All of our background, all of the years of research have been in stem cells. And we were able to open, as I mentioned, this stem cell clinic in Quito, Ecuador. But then we're instrumental on opening other clinics throughout the Central America and the Caribbean, as Guatemala, Trinidad Tobago, and Jamaica. Right now, this is our headquarters. So if you're in Miami, well, the pandemic right now is really difficult. Neither the building or we let many people come in, but if everything goes back to normal, it is my pleasure to shadow there as well. So we are a publicly traded biopharmaceutical company. We're committed to the research, development, and manufacture of new biologic medicine with a focus on the current and potential regenerative therapeutics. We are located, as I mentioned, in the CIC, or Cambridge Innovation Center. This is a building called Life Science and Technology Park in Miami. And we're registered with the FDA as a human cell and tissue establishment. So what do I do and what are you here for? I am here to talk to you a little bit about regenerative medicine. So what is this field of regenerative medicine that when I went to school, nobody talked about it? When I went to do my master's degrees, nobody even knew about it. So I was part of the group that had to auto-educate myself and start collaborating with more physicians and scientists that knew about it without a formal degree of you became a regenerative medical doctor. I still don't think there is a branch that teach you that, but there are now many universities that are teaching stem cell derived the aspects of this field of regenerative medicine. So regenerative medicine is the branch of medicine specializing in the replacing, engineering, or regeneration of human cells, tissues, or organs, focus on developing and applying new treatments to heal tissues and organs to restore function due to the aging, disease, damage, or effects. The field's goal is to optimize the human body's natural ability to heal itself. And this is probably the biggest highlight that I want to leave with you, is that the human body is so perfectly designed that if we give them a correct information, the body has the ability to heal itself. up to a point. Um, and just as a really simple example is if you cut yourself in a matter of minutes, if you apply pressure, there will be all your platelets, but also those stem cells in the area that will start commanding everybody else to do what it needs to be done, right? So it is not too foreign, the idea of regenerating the body, but it has taken up to more than 15 years from my side and our company specifically to understand where and what we can do to be able to develop a specific drug that can be um, given as a drug for a specific ailment. So it goes beyond treating symptoms. As you will go through med school, most of the training will go into treating those symptoms. And I think the most important thing as physicians is always to look for the root cause, right? And work from the root cause up. It is not easy. It's a challenge, but that should be the goal. So regenerative medicine includes tissue engineering and biomaterials and cellular therapies, medical devices, and artificial organs. So it's a really broad spectrum of medicine when we're talking about regenerative medicine. I'm going to be focusing a little bit more into the cell-derived therapeutics for you to understand how did we get to where we are right now. So the two big scenarios when we're talking about cell-derived therapies is either we're talking about autologous from the patient's own body or allogeneic from a donor, right? In autologous therapies, we can work with cellular tissue-based therapies. We started with bone marrow derived stem cells or the hematopoietic stem cells. Then the world transitioned more into exploring the adipose derived stromal vascular fraction or adipose derived stem cells because we found out that there were more of the regenerative stem cells there, the mesenchymal stem cells, the ones that can regrow most of the organs. The hematopoietic stem cells are the ones located in the bone marrow. Even though there's some MSCs or mesenchymal stem cells, most of them are the hematopoietic, the ones that will derive lines from the blood. And many of you must have heard of the PRP or the platelet-rich plasma that is derived from blood. So all of this can be harvested from the patient, and after, let's say, just centrifugation and a little bit more, can be injected back into the patient. Those were our first years. We explore bone marrow and adipose, and it is fascinating the amount of results that we were able to have. But we understood that depending on the patient, and most if you have patients that are older and that have different conditions, medical conditions, and that their environment is not a good environment, then the results vary a lot, not a little bit, but a lot. You can have 4 patients that are 50-year-old that come to treat their osteoarthritis of the knee or their knee pain, and we do the exact same procedure, and you will have different results on all of them. And that depends on that patient's own stem cells and the ability for them to regenerate themselves with those stem cells from the host, from the patient's own body. So when we understood after doing so many treatments that our therapy was not giving consistent results, we said, okay, we have to go back to the drawing board and see where can we get better stem cells or regenerative cells to be able to, one, produce many of this product, and two, make sure that the results can be consistent. So the field of regenerative medicine for us opened up into the donor or the allogeneic therapies. Most of it coming from the placental derived therapies, or we call it perinatal tissue derived therapies. So placenta based therapies or perinatal tissue therapies are those tissues that are between the mom and the baby. So, and this is either the cord blood, the membrane, the amniotic membrane, the chorionic membrane, the fluid, the cord blood. All of these are tissues that are not from mom and not from baby. And it's very interesting because these tissues are the ones that let that baby, which is a total different organism, live inside of mom without mom rejecting the baby. So this shield tissue called perinatal tissue, it's extremely extraordinary. All the ability that it has, and you'll learn through med school, everything that the placenta does for the mom and the baby. But talking about regenerative medicine, we started really looking into what aspects of this tissue can be harvested so we can produce better therapeuticals. So this is a tissue process from human amniotic membrane and fluid. And this is the most important thing, because most of the people, when they hear stem cells, they immediately think that they are coming from aborted fetuses, or that there's an ethical component to it. So as I've tried to explain, you can do stem cells without doing any of this harm and any of this unethical thing. Most of the people that are working right now in stem cells throughout the world are not doing any harm to any baby, no abortions, and there's no unethical procurement for these cells. So in our case, we do collect the tissue from only scheduled C-sections, where we have completely vet the mom and the baby as a healthy environment, as them being the perfect donor to donate this tissue. This placental derived therapies are coming from a tissue that usually just gets discarded. So it's called medical waste. And you will see when you rotate through your OBGYN rotations that indeed after every C-section or after every delivery, the placenta, the cord blood, everything gets discarded. So we went into venturing and understanding what is in these tissues that can be regenerative. So as I said, avoids any ethical or moral concerns. And there is a record of usage of this kind of tissues, specifically the amniotic membrane, since 1910. So it's not new for medicine to use this kind of tissues after you've done a full-blown processing of the tissue or the membrane for it to become deemed for donation. And there's case series that have been documented success in a multiple of systemic and local pathologies. I'm going to give you one example. Of the eye surgeons are using this amniotic membrane after they do their surgery, so the eye can recover much faster. And it's pretty common, and it's nothing from out of this world. So in other professions, other medical professions, they are not too familiar about perinatal derived donated tissue. But as I'm saying, this has been around for over a century. So this is how we got here to our product called Sofen. It's a product that it comes from the perinatal derived tissues, and that it does not contain any cells, right? But we've been able to maintain all of the particles that are regenerative without all of the other things that we don't want from that tissue. So as I mentioned, Sofen is an acellular drug, meaning that there's no cells, and it's manufactured for clinical use under CGMP compliant manufactured conditions. To understand a little bit of what is in the product, I've divided it in several biological composition sections. This is the soluble proteins. It contains over 300 different cytokines, chemokines, and growth factors. And these signaling molecules act on pathways that affect tissue and immune cells. So this type of proteins tell the immune cells and other things what to do and what not to do. And these are the specific things that we have highlighted from these proteins. These 300 proteins can be proangiogenic. Angiogenesis means that you create new vessels, and new vessels are needed in areas where you need more. So what do the vessels do? They bring oxygen and they bring nutrition. So most of the, when you have a problem, most of the areas mean that they don't have too many of these vessels. So being proangiogenic, it's extremely beneficial. Anti-inflammatory, that's self-described, right? Because most of the pathologies that we treat are inflammation related. So this type of proteins are very anti-inflammatory. Immunomodulatory, that just means that it talks to the immune system or your soldiers to better act in different cases and scenarios. Tissue repair and pro-metabolic. So all of this allows your body to have building blocks or to have correct information to recreate what it was supposed to do. Hyaluronic acid is another component of our product. This hyaluronic acid is usually used for joints when you need more lubrication. So it is present in the fluid. And this is what our specialty is. After learning so many years of stem cells, we switched into this new category, exosomes. Exosomes, and I'm going to go a little bit deeper about what are exosomes, but they are present in our product as well, 400 billion of exosomes per ml. And I want to explain to you how we quantify these exosomes. So this is a nanosite, and I don't want to bore you, but this is what we're looking for. This small nanoparticles that are carrying a set of information. So exosomes are extracellular vesicles that have an endosomal origin. So every single cell produces this kind of vesicles that have information inside. They're released by many different cell types and participate in various physiological or pathological processes. Exosomes work as information messengers to recipient cells. Depending on their origin and information transferred, they can alter the fate of the recipient cell. The size is very specific. They have to be between 40 to 200 nanometers. So we're talking about really, really, really tiny. And we thought 10 years ago, 20 years ago, that these little bubbles that the cell secreted were actually garbage being discarded because there was no technology that can actually see inside of these vesicles. So it's been very recently that we have understand what is inside of these vesicles. We've seen inside of them. And now we can say, oh, this actually is not garbage being discarded by the cells. There's something in them. So this is mainly how exosomes are formed. As I said, they are coming from inside the cell. It's an inbudding of the endosome that creates them. And then it loads certain proteins, enzymes, microRNA, messenger RNA. Now that that the vaccine is out and that Moderna and Pfizer have messenger RNA vaccines, it's been much easier to explain to everybody what is inside of these exosomes and for people to understand that these are snippets of RNA that carry a specific message. So then they're transported to the side of the cell. They're secreted from the cell. And after they're secreted, other cells in the neighborhood or in other parts of the body can actually digest them and then decode that message. So it's very important to understand this because you can communicate from cell to cell with this specific message. So I think I'm gonna answer the questions at the end. I picked one of our case studies for me to discuss. So I just wanted to tell you, a year ago that we were hit by the pandemic, all of our research has been developed for lung injury and for osteoarthritis. So those two things we were really focused on: lung injury to create the rationale to treat um, this lung degeneration condition called COPD. And our other side of interest was always to study osteoarthritis. So this is what we were studying. This is all the rationale we were preparing. And then COVID happened. So our scientific team, our regulatory team said, we have so much information right now that actually can help us treat these patients with COVID because the immune system reacts specifically in the lungs. And the lung injury, it's somehow like the things that we were studying. So we presented our IND, it's called Investigational New Drug Application to FDA. It's actually like a 400-page book. If you have Instagram, you can check it on my page. I did uploaded, I would say, not even like a month, 2 months ago, those actual books that we submitted to FDA. And we were granted the approval for us to study our product for this. So imagine we've been working for over 15 years with stem cells, autologous stem cells first. Then we moved into perinatal derived stem cells. And then we said, you know what? There is more information if we, or there's more regenerative compositions if we work with not the cells, but everything else that will come from the cells as the exosomes and the other proteins, as I mentioned, and hyaluronic acid that is present in this perinatal tissue. So after getting the approval, we were able also to submit many emergency case studies. So emergency compassionate use INDs. And this is one of them. And I'm going to explain to you a little bit of what we did with this patient and how we treated him. So it's a 55-year-old male, actually a surgeon. His weight, 79.5. So this patient has been hospitalized for 7 weeks due to mild to moderate acute respiratory distress syndrome due to COVID. During his hospitalization, he was admitted twice to the ICU, but never was intubated. But imagine his condition had to be extremely advanced for him to be moved from the floor to the ICU due to this extreme infection. At the time of the discharge, the patient was physically limited due to severe deconditioning and having shortness of breath while performing limited activities of daily living, like eating meals, showering, and a short distance walking. He expressed that he couldn't even walk from his bed to a bathroom, and shaving was really, really hard. This patient used to be a marathon runner and a surgeon that you can imagine a surgeon has to endure so many hours standing and being totally focused when you're opening and fixing somebody inside. So from him being such a thriving 55-year-old was even at discharge, hospital let him go home with all of the symptoms still being present. So his chest x-rays revealed bilateral pneumonia at baseline, meaning baseline of when we started treating him. So some of the things that we have to ensure that we do is to follow all of the points for to collect data for this kind of cases, right? So first we had to know that the patient was COVID positive at what point, that he signs an informed consent, understanding that he's going to participate in this kind of trial for an investigational new drug. Collect all of the demographics, medical history, physical exam. The chest x-ray, as I mentioned, was showing that bilateral pneumonia. And then we did some laboratory testing of biomarkers. So IL-6, TNF-alpha, D-dimer, and CRP. This one specifically look how are your inflammatory markers, like the biomarkers. So we also did your regular CBC and differential, a complete metabolic panel. And we tested this day 0, day 4, day 8, 12, 21, and 28. So we could see actually how his blood-derived numbers were changing, besides the chest x-ray as well. And we treated him with our product on the days 0, 4, and 8. So he received 3 treatments with a space of 4 days apart. We always, in any trial, always look for adverse events assessment and infusion associated adverse events within 24 hours after each infusion. None of them were present. So these are the changes that happened in this patient. On the day of the first treatment, the patient's O2 saturation remained low at 96%. By day 8, prior to the administration of the 3rd dose, the patient reported no signs of fatigue and shortness of breath, and his O2 improved from 97 to 98 after the first dose. So you can see how only on the days of treatment, he started to get better. But furthermore, after completing the 28 days, the chest x-ray revealed that there was no more pulmonary abnormalities. It was a completely normal chest x-ray. And patient was able to return back to work and be in the OR after 1 month after initiation of the protocol. This was a patient that said, I think I'll never go back to work. And these patients now are known as the long haulers, the COVID long haulers. It's a bracket of patients that got the infection of COVID, and even if the infection was mild and patients didn't even get to the hospital, there's many patients reporting that they have this mental fogness, this shortness of breath with exertion, especially just by walking or exercising minimally. They have palpitations. So it is a bracket of patients that we are extremely interested in working. We have submitted our IND specifically for these patients because of these changes that we saw. So we've treated 4 of these cases under emergency compassionate use, and all of them are just showing this kind of results. But again, as a scientist, as a physician, we know that we need to make this a bigger trial to actually look for those bigger results, right? In a population that is double-blinded, placebo-controlled, randomized, multi-center trial, which is what this is like the highlight of all the studies, right? So this is my quote. I love to always give a quote, and for all the people that are suffering with COVID, that have passed through all of this, it's been a really challenging year for all of us. And just so you know, just not to give up, that science will show up, that knowing that behind the scenes, there's many scientists, technicians, and physicians, and just in the healthcare arena that are doing everything in their power to try to find for solutions for these problems. And I think that the vaccine was one of those. It's a vaccine that has been worked for many years, for over a decade, specifically with messenger RNA, and they were able to transition all of their data prior and specifically to this. So I'm super open for all your questions. Let's see. Maybe I can leave it here. So
Dr. Mitrani, there are some questions in the chat. Would you like me to read them to you or can you access?
I found them.
Okay, perfect.
So Kate says, since you were interested in research, why did you opt from MD PhD as opposed to pathology with just MD? Um, well, life just kept going the way it was going. And even though I specialized and I thought I was going to be a clinician working with my my specialty with neural therapy and helping patients with pain, specifically with what I learned to do. But again, we were presented with that opportunity that could not refuse. And pathology specifically is you get samples of different tissues and you get to read those tissues, right? So you as a pathologist, you don't get to treat patients, you get to just analyze samples of specific tissues, which is amazing. I have so many pathologist friends, and even though we're all in the lab and under the microscope, it's totally a different approach. So that would be that one. Let's see, how much of your job is clinical and how much time do you spend in the lab? Well, um, at one point I was really bummed for the fact that I was not treating patients and not seeing patients until this year that we were able to submit so many trials, and now I get to see patients through my trials. And even though I don't get to meet them and um, go through their medical history, I am working with the physicians that are treating them. And then I'm getting to see how our product is actually impacting the lives of those patients and therefore their families. So I don't do any clinical anymore. I don't see any patients. Most of my time I am spending in the lab, but I manage this. I'm the co-founder of this company, so I do a lot of work on the computer. So I will be either in my office or in the lab working with my team. I have an unbelievable team from with many scientists that study specific things like cell culturing, for example. We have the ones that only specialize on the devices that we use, and so on. So I get to experience different sides of being a scientist in the lab, but also I get to manage my, I call my baby, my company. And that is, I'm going to use this opportunity to tell you, you're going to go through so many years of study, so many years of burnout, because studying medicine is not a piece of cake, and only the toughest of the toughest will survive. And expect to be broken into pieces, but expect to just stand up, put your head up, and keep going, because at the end of the day, the reward of seeing your patients and the family from your patients change completely is so worth it. So that side of studying medicine is so important for you to just continue doing it. It's not an easy task, but always remember this: you're going to have to learn how to run a business as well. Not everybody will stay in the hospital and work for the hospital. If you decide to have your private practice, you're going to need to know how to run a business. And that's something that they don't teach us. The same way as nutrition, they don't teach us, running a business, they don't teach us. So if you're in a early age right now and you can do two careers at the beginning, because doing an MBA or doing some kind of business related will be a short amount of time, studying medicine will be way longer. And when you've finished 10 years, 12 years after you have your MD and you have your specialty or your subspecialty, you are left alone in the field of, okay, now you're an adult and you have to take care of yourself and your family. And if you don't know how to run a business, most doctors fail at that. So just my 2 cents on that. How is your lifestyle as a physician scientist? Do you have a nice work-life balance? That was Shentruan. Hopefully I did not Centruan. Hopefully I said it correctly. I look for a lot of balance in my life. This year has not been easy. I've never experienced extreme burnout as this year, but you can ask any physician. This year has been extremely challenging. We are in the forefront of trying to find a solution. So for me and my team, it has been extremely hard, but nevertheless, I have never lost the sight of taking care of myself, because I understand that I am the only one responsible for me. So I since I was little, I've done a lot of meditation. I learned some yoga. So I do a lot of yoga in the water, in the paddleboard. That is my avenue and my outlet. I love to work out. That is something super personal. I love to lift weights really heavy. And I'm a vegan. I'm a plant-based physician. So I look for ways to make sure that I am taking care all of the time. I can tell you, when I went through med school, you don't eat, you don't pee, you don't poop, you don't sleep, but that's the way it is. And you are young and you're able to do it. And it's not forever. You will one day be out of that cycle. It's a very important cycle though. But after going through med school and all those hard years, I made sure to find that balance between what I am doing and being a human being. Rita, how were you able to develop this drug to help people affected with COVID? What resources did you have which helped you generate this drug with a relative short amount of time? Yeah, so what I was saying is that our biggest focus on our company was, we were working with University of Miami for lung injury models. So and specifically for BPD, that is bronchopulmonary dysplasia. So we were already almost a year into that specific work with BPD. So bronchopulmonary dysplasia is this disease that the babies that are born before their time get when those lungs are exposed to oxygen. So up to a point in their life, those lungs are only there working with water, right? So when they are born prematurely, they get exposed to oxygen, and oxygen bursts the alveoli. The alveoli are these sacs where there is the gas interchange. And when the alveoli burst, they don't work anymore. So there's no more tissue to do this oxygen and CO2 interchange, or the gas interchange, right? So we've been working with that in models that actually show that there is a regeneration on those cells. And the same thing, we were working specifically for BPD. We were working for our future IND on COPD, which is a chronic obstructive pulmonary disease. And COPD happens, and most of it, I don't know the percentage, but it's a really high percentage from people that smoke. So at the end of the many decades, the lungs just start dying. So the alveoli, or that tissue, starts dying. So we were working with this model of lung injury to be able to transition into COPD. And it was many years of us working on this, which let us have all of that rationale to present to FDA to say, hey, if the lung injury that we have shown that it can be reverted, and that acute respiratory distress syndrome that COVID is producing, it's pretty similar in that inflammatory, because the immune system just like floods the lungs with a lot of water. So it more or less was the same scenario. why don't we go ahead and explore that option? And here we are a year later, and we have done several patients with this, and we are going along with more and more trials to continue exploring and understanding what it is. Zrikar says, as you have said that you are trilingual, would you please explain just how important it is to know one or more languages in the medical field? Oh my God, representation is so important. Now, thanks to this pandemic and all of the racism that has been exposed, I think it's so important from wherever we come from. And when we see a patient that looks like us, and that they get to see that we as physicians are there as well. It's extremely important. Not only for the medical field, I think, and I say this to my daughter, when you know more than one language, you can go throughout the world and actually talk to them in the same language, and the culture and the way that you understand the culture just becomes a different way. It's extremely important right now that the world is so united with this social media aspect that we can all communicate with each other, to know more than one language. Knowing one and two languages, it's too little. So I do think, and I know all of you are pretty old, so it's easier to learn when you're younger. But nevertheless, I learned Portuguese 10 years ago, and it's phenomenal. It's so fantastic to know one more language, and the way that I can actually communicate with that population, it's so important. So yes, representation matters, and you just keep going and use all of your skills.